Ladies and gentlemen, our program will begin in 15 minutes. Ladies and gentlemen, our program will begin in 5 minutes. Ladies and gentlemen, our program is about to begin. Please welcome the Chief Executive Officer of the American Association for Cancer Research, Dr. Margaret Foti.
Good afternoon, everyone. On behalf of the American Association for Cancer Research, I have the great honor to welcome all of you who are joining us virtually from Capitol Hill, as well as from across our country and around the world, for this special congressional briefing where we are unveiling the landmark AACR Cancer Disparities Progress Report 2020, Achieving the Bold Vision of Health Equity for Racial and Ethnic Minorities and Other Underserved Populations. My name is Marge Foti. I serve as the Chief Executive Officer of the American Association for Cancer Research, AACR. The AACR is the world's first and largest professional organization dedicated to advancing cancer research and its mission to prevent and cure all cancers. Over the years, the AACR and its more than 47,000 members from the United States and 126 other countries around the world have been at the forefront of every major breakthrough against cancer. Our organization has also been leading numerous science and public policy activities to improve our nation's health. To accomplish our goals, the AACR marshals the full spectrum of expertise in cancer research to identify the top scientific priorities, convenes conferences and educational workshops all over the world, publishes 9 high-impact, peer-reviewed scientific journals, produces a magazine for cancer survivors, patients, and their caregivers, and works to raise funds from the philanthropic community for highly meritorious research that has the potential to prevent and cure the more than 200 diseases we call cancer. The AACR also actively communicates with legislators, other policymakers, and the public about the value of cancer research and the cancer-related sciences, in saving lives from cancer and in making sure that these advances in research and treatment benefit everyone equally. We are here today at this special virtual congressional briefing because of the monumental importance of cancer health disparities. The idea of undertaking this historic initiative of producing the very first progress report on cancer health disparities was conceptualized about 2 years ago when the AACR's leaders, as well as our member scientists and physicians who represent minority populations and the underserved, determined that realizing the vision of health equity would require a comprehensive plan to identify the parameters of this major public health problem, inform and educate policymakers, regulators, and the public about the enormous scope of the problem, and outline the effective steps that are needed to confront the problem head-on. Our original plan was to issue this historic report in March 2020. Of course, those plans were upended by the COVID-19 pandemic, a situation that has further revealed the problem of health disparities in even broader and starker terms, as African Americans and other communities of color are much more susceptible and vulnerable to the coronavirus. The AACR has long recognized the need to address cancer health disparities through its programs and initiatives. Our organization has a dedicated history of proactively working in a number of ways to address the enormous public health challenge of cancer disparities. As one example of our work, the AACR's Minorities in Cancer Research Membership Group, MICR, which is celebrating its 20th anniversary this year, has been leading the way in increasing the number, participation, and recognition of minority researchers in the cancer field. Diversity and inclusion in our field are extremely important for accelerating the pace of progress against cancer, and a lack of racial and ethnic diversity in both the cancer research and healthcare workforce is one of the major factors contributing to cancer health disparities. The AACR's annual conference on the science of cancer health disparities in racial ethnic minorities and the medically underserved will be marking its 13th year of existence in October of this year. Developed in collaboration with AACR's Minorities in Cancer Research Council, this conference strives to bring the latest scientific and policy advances in cancer health disparities to the scientific and advocacy communities. A critical tool in combating cancer health disparities is patient engagement and advocacy. The AACR added its renowned Scientist Survivor program to this conference to increase and support its partnership with patient advocates from underrepresented populations. Also, in 2018, the AACR formed a Cancer Health Disparities Task Force and hosted a second think tank of leading experts and key stakeholders, which had as one of the strategic goals charting the future direction of our cancer health disparities programs and identifying actionable steps that will accelerate the pace of progress in this vitally important area. In summary, the AACR is very proud that it has been proactively working for many years to address these issues. The exciting release of today's report, which was produced under the dynamic leadership of Dr. John Carpton and a highly knowledgeable steering committee, is the culmination of AACR's many programs and initiatives that have been launched to eliminate cancer disparities at the earliest possible time. This report will undoubtedly increase public awareness and understanding of cancer health disparities and underscore the urgency of cancer disparities research in saving more lives from this disease. Further, the report emphasizes the need for increased annual federal funding for the government entities which fuel progress against cancer health disparities, in particular the National Institutes of Health, the National Cancer Institute, the Food and Drug Administration, and the Centers for Disease Control and Prevention. The report also underscores the urgency for science and public policies to address this pressing public health challenge. And now I invite you to watch this inspiring video.
At age 49, I was diagnosed with triple-negative breast cancer.
Well, they found out after the biopsy that I was an adenocarcinoma, that it was a colon cancer.
When the doctor said prostate cancer, for me it was kind of like a big, dark, gray cloud came over my head at that moment.
When they took the bone marrow, they came back and they said he had leukemia.
Cancer disparities is a complex issue. And historically, there's been a lot of work trying to understand the role of socioeconomics, which undoubtedly contribute to a lot of the disparities that we see.
When I had the second breast cancer diagnosis, this is when my problem began with my insurance. My insurance didn't cover the surgery that I was going to have at one particular hospital.
Looked and sought and searched, and I wasn't getting calls back, or I would call clinical teams and they would ask me to send in my medical history. And in 2017, my medical history was 500 pages. I wasn't working at the time. You want me to send in 500 pages via a fax at $3 a page? How archaic.
We are learning that in some cases with equal treatment, equal disease management, we can begin to see equal outcomes. But hasn't always been the case.
I met Dr. Muncie's group in 2009 and was followed by him to 2017 as smoldering myeloma.
Mr. Johnson has been my patient. He has been coming to Dana-Farber for a number of years. Mr. Johnson proves the point that when you get a good access, you could do well.
After the CAR T therapy, Fernando was, we were at the hotel, he was jumping on the hotel bed, he was bouncing around. I had to tell him to stop because he has low bone density. I'm like, no, you might break something. I basically believe the CAR T was a miracle for him.
What I'm excited about now is that we have amazing tools and technologies and methodologies that are really allowing us to hone in on biological factors that might be influencing these disparities.
During the time of my chemotherapies, I had to undergo genetic counseling and genetic testing, and I tested positive for the BRCA1 mutation.
My second opinion said to me, you might want to think about genomic testing because you might have mutations that may be driving your cancer. And so all of this information led me to go out there and seek, a trial.
We need to diversify clinical trials, increasing the numbers of minority individuals participating in these trials.
They said, well, we do have a clinical trial that we're looking to get some folks into. First of all, I want to see if I can take care of me. And then I started thinking about if I'm in a clinical trial and what I do helps someone down the road, then I've done something. I've paid it forward.
As we look towards 2025 and 2030 is when we begin to integrate the societal issues and how that can affect biology. We've made progress in a number of areas, again, particularly on the biology side, but I still think we have a long ways to go.
As a Hispanic living in Puerto Rico, sometimes we feel that we are a minority inside a minority. I know that there are a lot of programs that need to be created and done. But for us right now, Hispanics living in Puerto Rico, we need the ones that are already currently up and running, we need to get them here.
The African American community, sometimes in these particular communities, they don't have the proper resources. I would say to Congress to try to get some resources out in the community available to the people that cannot afford insurance, that do not have insurance, and to make it available to them.
It's for the generation that comes after, because we don't want to have to live through all these toxicities for the rest of our lives. If we can improve research and we can improve the treatments, I believe it's possible. I think we have really amazing, talented people around. And I think it's important that our elected officials, that they think of us.
It is now my great pleasure to introduce two influential members of Congress who have provided remarks for today's briefing. The first is Congressman Benny G. Thompson, who represents the 2nd Congressional District of Mississippi. He has been a member of the House of Representatives since 1993 and is the Dean of Mississippi's Congressional Delegation. Congressman Thompson currently serves as the chairman of the House Committee on Homeland Security. He has been a member of the committee since its establishment as a permanent standing committee in 2005. Congressman Thompson has been a long-standing champion of addressing the problem of health disparities. He authored the Health Care Fairness Act of 1999, which created what is now the National Institute on Minority Health and Health Disparities within the National Institutes of Health. The bill was signed into law in the year 2000. Congratulations on your work, Congressman Thompson.
Thank you for inviting me to give some brief remarks. I'd like to applaud the American Association for Cancer Research for their inaugural Cancer Disparities Progress Report for 2020. This information is absolutely needed among communities of color. I'm proud to say that I was an original sponsor of a bill during the 106th Congress, which created what is now the National Institute on Minority Health and Health Disparities. For persons of racial and ethnic minority populations, health disparities can mean lower life expectancy, decreased quality of life, loss of economic opportunity, and perceptions of injustice. For society, those disparities translate into decreased productivity, increased healthcare costs, and social inequity. Though health indicators such as life expectancy and infant mortality have improved for most Americans, some minorities experience a disproportionate burden of preventable disease, death, and disparity compared with non-minorities. Health disparities can stem from health inequities, systematic differences in the health of groups and communities occupying unequal positions in society that are avoidable and unjust. For racial and ethnic minorities in the United States, health disparities take on many forms, including higher rates of chronic disease and premature death compared to the rates among whites. It is important to note that this pattern is not universal. Socioeconomic factors, lifestyle behaviors, social environment, and access to clinical preventive services contribute to racial, ethnic, and health disparities. I believe that reducing racial and ethnic health care disparities is essential for better health care outcomes and for lowering health care costs. With that being said, thank you to the American Association for Cancer Research for producing this much-needed report.
The second individual is Congressman Mark Wayne Mullen, who represents the 2nd Congressional District of Oklahoma. He has been a member of the House of Representatives since 2013. Congressman Mullen currently sits on the influential House Energy and Commerce Committee and its key subcommittees on health, environment, and climate change, and oversight and investigations. Congressman Mullen is a vocal advocate of the importance of addressing health disparities, especially in the Native American community. As a member of the Cherokee Nation and one of the 4 Native Americans in the House, Congressman Mullen has publicly called for hearings to address the health issues faced by Native Americans. In a June 2020 Health Subcommittee hearing, Congressman Mullen stated that Native Americans, as well as those in rural areas, are being left out disproportionately of important scientific studies that are examining the problem of health inequalities. Congratulations, Congressman Mullen, on your extraordinary work.
Hi, I'm Congressman Mark Wayne Mullen from District 2 of Oklahoma. I represent a very rural part of the state. In fact, we cover the entire eastern side. We run from Kansas to Texas. And when we start talking about specialty care, in cancer or really any type of specialty care, there's a huge difference between those that may live in a major metropolitan area and the type of care we might receive in rural parts. And through COVID has been devastating to our country, but it's also exposed some holes that we have, and it's also exposed the need for telemedicine. Is it the same as having somebody in the room with you? No. But does it allow us to have specialty care in a more convenient spot in an area that maybe a person in a rural area couldn't be reached? Yes. For us, let's say in Westville, the nearest cancer hospital to us would be Tulsa, which would be 90 miles away. And honestly, most people from there will actually go on to Houston, which is 11 hours away if you drove. It's inconceivable for us to do this. But then let's start talking about pediatric cancer care. The need is even greater. And as an adult, it's one thing for us to suffer. It's a whole nother idea when you have a child that is suffering. And so when we start talking about advancing the care of the patient, we need to bring in the technology aspect of that too. And I'll tell you, as lawmakers, sometimes we get lost in the shuffle of trying to figure out how to regulate even what we got, much less the way technology is rapidly changing. But your advocacy is vitally important to stay on the forefront, to stay out there telling your stories, talking to us lawmakers, letting us know where the industry is moving and how it's affecting the patient and the caregiver. So thank you for being involved. Thank you for constantly staying informed. May God bless you, and may God bless the United States of America.
And now I am pleased to introduce our esteemed AACR President, Dr. Anthony Ribas. Dr. Rebus is professor of medicine at the David Geffen School of Medicine at UCLA, director of the UCLA Johnson Comprehensive Cancer Center Tumor Immunology Program, and director of the Parker Institute for Cancer Immunotherapy Center at UCLA. Dr. Rebus is an internationally recognized physician scientist whose translational and clinical research focuses on developing new therapeutic options for patients with malignant melanoma. He has been at the forefront of precision cancer medicine and immunotherapy for many years. Dr. Rebus also served as program chair for the AACR Annual Meeting 2020, the preeminent international meeting in cancer research. Due to the pandemic, an in-person scientific program was adapted into 2 groundbreaking virtual annual meetings under his innovative leadership, with more than 100,000 registered attendees from 140 countries around the world for both virtual meetings combined. To rapidly respond to the ongoing COVID-19 challenges, Dr. Rebus formed an AACR COVID-19 and Cancer Task Force that includes experts from all the disciplines relevant to this disease and its impact on cancer. One of the first actions spearheaded by the task force was the organization of an AACR virtual meeting dedicated to COVID-19 and cancer and the related scientific and policy advances. This exceptional AACR conference, which was held in July, focused on the rapidly emerging data in basic, translational, and epidemiological research related to COVID-19 and cancer. The COVID-19 conference and the AACR virtual annual meeting included sessions on the critical topic of health disparities. Led by Dr. Rebus, the task force has also made addressing the cancer screening gaps created by COVID-19 a priority. We are pleased to have Dr. Rebus join us today as he is a champion in the fight against cancer health disparities. At our virtual annual meeting in June, he created and led a panel discussion titled Racism and Racial Inequities in Cancer Research. The panel, which included Drs. John Carpton, Marcia Cruz Correa, and Robert Wynn, was convened to present an open and frank discussion about this timely and important topic, leading to concrete steps and initiatives that the AACR can take to eliminate racial inequity in all of its forms. We are so proud to have Dr. Rebus as our 2020-2021 AACR president. Please welcome Dr. Tony Rebus.
Thank you so much, Marge. Hello, everyone. My name is Tony Rebus. I serve as president of the American Association for Cancer Research, and I am delighted to participate in today's event to release the AACR Cancer Disparities Progress Report 2020. Research is driving tremendous progress against cancer and other human diseases, but the grim reality is that these advances have not benefited everyone equally. Progress has come too slowly for people of color, and the monumental cost of cancer health disparities in terms of healthcare inequalities, premature deaths, and the impact on communities must be immediately addressed. During my year as president of the AACR, I am committed to continue and build upon the past efforts of the AACR to address the enormous public health challenge posed by cancer health disparities. An individual's race, ethnicity, geographic location, or income should not dictate his or her cancer outcomes, but unfortunately, this is exactly what is happening today. For example, in the US, Black men face more than double the rate of death from prostate cancer than men of other racial and ethnic groups. Hispanic children remain 24% more likely to develop leukemia than non-Hispanic children. Women of low socioeconomic status with early-stage ovarian cancer are 50% less likely to receive the recommended care than women of high socioeconomic status. It is absolutely unacceptable that advances in cancer care and treatment are not benefiting everyone equally. An individual's race, income, place of residence, or health insurance should not determine access to the latest cancer treatments. As an organization focused on the conquest of cancer, whose core values include equality, diversity, and inclusion, the AACR is fully committed to increasing the number of racial and ethnic minorities in cancer research workforce. Even as our nation has grown increasingly diverse, the number of minorities working in the biomedical research community has not grown proportionally. In fact, less than 11% of researchers in the US are members of underrepresented groups. This also includes American Indians, Alaskan Natives, Native Hawaiians, and other Pacific Islanders. The AACR is also extremely concerned that racial and ethnic minorities continue to be underrepresented in cancer research and clinical trials, especially because the different ages, races, and ethnicities may respond differently to cancer treatments. Fortunately, this particular area, strong efforts are currently underway to increase the number of individuals from diverse populations to participate in clinical research. For example, the FDA recently issued a draft guidance for the pharmaceutical industry with recommendations to diversify clinical trial populations. The guidance followed a public stakeholder workshop and is intended to improve the collection of clinical data that are more relevant to the real-world population of people with cancer. The AACR also recently partnered with the FDA in February to explore this topic at the FDA AACR workshop to examine underrepresentation of African Americans in multiple myeloma clinical trials. Sadly, as we have seen in stark terms over the last 6 months, the burden from the coronavirus pandemic has not been equally felt, with the problem of health disparities in America's communities of color being magnified in dramatic fashion. Black, Indigenous, and Hispanic Americans are more likely to be infected with COVID-19 and are more likely to die of the disease. More specifically, African Americans account for 13% of the US population, but about 23% of the deaths from COVID-19. In fact, recent data also reveals that Black people are 3 times more likely than white people to contract the coronavirus, 6 times more likely to be hospitalized, and as a result, is as likely to die from COVID-19. The CDC reports that Latinos are hospitalized from the virus at 4 times the rate of white Americans. And 26% of people who have died from COVID-19 in this country are Latino, which is clearly disproportionate vis-a-vis other populations. Native Americans are also facing a disproportionate burden of the COVID-19 pandemic, with higher infection and mortality rates than the overall US population. At the session at the AACR virtual meeting, COVID-19 and Cancer, held this year on July 20 to 22nd, researchers discussed a wide range of emerging research about how minority groups are faring during the pandemic. Much like disparities in cancer, disparities in COVID-19 are multifactorial, with roots in socioeconomic problems that are under increased scrutiny in the US. To this point, the recently witnessed inhumanities against people of color have also refocused our nation's attention on the terrible issue of racism that exists in this country. Racism has resulted in a public health emergency, and it's critical that everyone plays a role in eradicating societal and economic injustices, as these are major barriers to health equality. To this end, I am pleased to announce today that the AACR is establishing a task force that will focus on racial inequalities in cancer research. The task force will include leaders across the country representing academia, government, industry, and cancer survivors and patient advocates. During this unprecedented time in our nation's history, there's a need for our nation's leaders to take a bigger role in calling out and combating systemic racism and racial inequalities. The major goal of the task force will be to discuss various ways to make positive change. It will provide leadership on the pursuit of initiatives aimed at addressing long-standing racial injustices in the biomedical field and in cancer healthcare. In summary, it is clear that we must do better as a nation to confront the serious problem of cancer health disparities. Today's report serves as a call to action for the cancer research community to commit to implementing the numerous action-oriented steps that are required to eliminate cancer healthcare disparities among racial and ethnic minorities and the underserved, increase minority representation in clinical trials, and achieve diversity in the cancer research workforce. I am pleased to introduce Congressman Will Hurd, who represents the 23rd Congressional District of Texas. He has been a member of the House of Representatives since 2015. Congressman Hurd currently serves as the ranking member of the Subcommittee on Intelligence, Modernization, and Readiness of the House Permanent Select Committee on Intelligence. He also sits on the House Appropriations Committee. Congressman Hurd is an enthusiastic advocate for increasing access to healthcare for all. He has co-sponsored legislation that would provide aid to localities to address COVID-19 among vulnerable populations and has supported numerous efforts to address health disparities by improving access to quality care.
Hey y'all, I'm Congressman Will Hurd from the great state of Texas. As a Black legislator and a representative of a 71% Latino district, I've come to learn that Black and Latino patients with breast, lung, colorectal, and prostate cancer are almost 30% less likely than white patients to enroll in clinical trials testing treatments for these 4 types of cancer. When families receive a cancer diagnosis, it's one of the most difficult things to hear. Sadly, this year alone, there will be an estimated 1.8 million new cancer cases diagnosed and over 600,000 cancer deaths in the United States. Each and every one of these people are a reason we must keep pushing for a cure for this devastating disease. The American Association for Cancer Research is high-quality, innovative cancer research is a vital piece of this puzzle as they work to create breakthroughs in medicine. As we continue to make progress in finding innovative treatments and ultimately a cure for everyone, we must ensure fair access to these resources for all patients. Oral chemotherapy is an innovative treatment, which represents 35% of the oncology development pipeline. But most of these medicines do not have alternative options, leaving patients with the burden of paying astronomical out-of-pocket costs or completely foregoing treatment. These figures are unacceptable in a nation that represents cutting-edge research in the medical field. While we do have work to do, I want to say thank you to the association for putting together this Disparities Progress Report so we can better educate ourselves on these issues and find ways to work together to fill these gaps. I'm proud to support bipartisan efforts in Congress to give patients more flexibility, transparency, and access to treatments such as the Cancer Drug Parity Act and the Lower Cost, More Cures Act. Through these bipartisan initiatives, we can reduce cancer disparities and fight for patients across the nation. The only way we are going to win this fight is if we work together. God bless you all.
I'm pleased to introduce Congresswoman Xochitl Torres-Small, who represents the 2nd Congressional District of New Mexico. She has been a member of the House of Representatives since 2019. Congresswoman Torres-Small currently serves as chairwoman of the Subcommittee on Oversight, Management, and Accountability, the House Committee on Homeland Security. She also sits on the Agriculture and Armed Services Committees. Congresswoman Torres-Small has been an advocate for health disparities with an emphasis on women, Latinos, and those in rural communities. She recently sponsored legislation that would increase health care across the rural populations during the COVID-19 pandemic.
Hello, Congresswoman Xochitl Torres-Small here, proudly representing New Mexico's 2nd Congressional District. It's an honor to help launch the American Association for Cancer Research's inaugural Cancer Disparities Progress Report. Hopefully, this new information can arm lawmakers with the data they need to better target efforts to address the underlying conditions that can contribute to poor health outcomes. As we know, some of the traits I love about my home are also what makes it tough to reach some basic healthcare services. It's why during my first term in Congress, I focused on addressing some of the conditions that keep New Mexicans from accessing the health care they need close to home. One of the first bills I introduced, the Resident Physician Shortage Act, aims to attract primary care providers to rural communities by increasing the number of Medicare-supported residency positions by 15,000. I'm hopeful that by bringing doctors in training to rural communities early in their career, they'll be encouraged to plant roots and provide care to residents across New Mexico who urgently need it close to home. I've also worked to address the rural maternity crisis facing many expectant parents in my home state. By introducing the Rural Moms Act, I hope that rural healthcare providers can leverage telehealth services to provide pre- and postnatal care for mothers who already manage several responsibilities in anticipation of delivery and with the addition of a newborn. I hope the combination of the two efforts can begin to address some of the systemic issues that contribute to a range of health disparities across New Mexico. I know that by working together, we can build a bright future for families nationwide.
Now it's my distinct privilege to introduce to you Dr. John Carpenter, who served as chair of the AACR Steering Committee of Experts in the field that developed today's report, a comprehensive document that will increase public understanding of cancer healthcare disparities and the importance of disparities research to saving lives. In addition to providing dynamic leadership for the AACR Cancer Disparities Progress Report, Dr. Carton is the director of the Institute of Translational Genomics and professor at the University of Southern California Keck School of Medicine. He is also the chair of the AACR's Minorities in Cancer Research Council. Dr. Carton also served as program committee chairperson of the AACR 2019 annual meeting in Atlanta, and co-chaired the AACR inaugural special conference on the science of healthcare disparities. Thank you, Dr. Carton, for your extraordinary commitment to this initiative.
Good day. I honestly can't imagine having a more honorable moment. I would like to thank all of the distinguished men and women in attendance today as we unveil the inaugural AACR Progress Report on cancer health disparities among racial and ethnic minorities and the medically underserved. I would like to thank Dr. Foti and the AACR not only for sponsoring the development of this historic document, but also for their long-standing commitment, support, and efforts towards exposing cancer disparities and their dedication to the pursuit of understanding the factors influencing disparities in cancer prevalence and outcomes among racial and ethnic minorities and the medically underserved. I would also like to thank my colleagues who comprise the Progress Report Steering Committee and contributing writers for their commitment and outstanding contribution and leadership in crafting this document and its contents. Undoubtedly, considerable progress has been made in our ability to fight cancer, as has been reported and stated previously, where we have seen an approximate 26% reduction in cancer mortality rates since the declaration of the war on cancer. However, it is also evident that despite these improvements, disparities in the incidence and death rates of cancer persist among underrepresented minorities and the medically underserved communities in our country. As such, in this initial progress report, we provide important background and context in describing various racial and ethnic minority groups and medically underserved communities of focus in this report that include African Americans, Hispanic, Latino or Latinx, Asian Pacific Islanders, and American Indian and Alaskan Natives. It also includes other medically underserved groups such as urban and rural communities and the LGBTQ community. Historically, a large component of cancer health disparities research has focused on racial and ethnic differences, where the vast majority of data exists, particularly as we consider African Americans and Hispanic Latinos. Aside from the devastating personal impact that cancer disparities exacts upon patients, their families, and their communities, it is also important to understand the significant financial burden that these disparities impose upon our society, where studies have shown that eliminating health disparities for racial and ethnic minorities from 2003 to 2006 would have reduced healthcare costs in the U.S. by $1 trillion. Thus, the impact of not addressing these disparities is far-reaching and will not only affect us now, but will also significantly impact generations to come. Among the major documented factors supporting these disparities are historical healthcare and socioeconomic inequities driven by systemic social injustices against various communities and populations within our country. Unfortunately, yet unsurprisingly, many of the factors that are at the heart of cancer health disparities have been put into full view as we now are observing significant disparities in SARS-CoV-2 or COVID-19 incidence rates and death rates among medically underserved communities and underrepresented minorities. Central to these disparities are those socioeconomic and environmental issues relative to access to care, particularly as we consider those safety net hospitals, which in many cases are under-resourced, but where many individuals in medically underserved communities receive their care, including cancer care. So there is unfortunately a compounding effect as we consider cancer and cancer disparities during the COVID-19 pandemic. Accordingly, we felt compelled to include a special chapter in this inaugural Cancer Disparities Progress Report entitled Disparities in COVID-19 and Cancer. For instance, due to stresses on the healthcare system by the pandemic, many critical cancer-related diagnostic and treatment procedures have either been delayed or in some cases canceled. These delays can give a cancer more time to grow in advance, making it even more difficult to treat once a diagnosis is finally made. It is already being predicted by leaders in the cancer research community that delays in screening and diagnostic procedures due to COVID-19 pandemic will significantly increase the burden of cancer in the U.S. for years to come. Of course, this increased burden is very likely to be heavier among racial and ethnic minorities and the medically underserved. Therefore, we are likely to see even greater cancer disparities as we look ahead, thus making this report and our response to its call to action and recommendations of even greater significance and urgency. Without a doubt, socioeconomic and inequities in access to quality care represent major factors influencing cancer health disparities, and these disparities will persist until we address these issues. As referenced in our report, 21% of African Americans and 18% of Hispanic Latinos were living below the federal poverty line in 2018. These factors play a central role in cancer health disparities as a whole and must be addressed. However, we also know that there are observed differences in the clinical characteristics of certain cancers when we look at tumors derived from racial and ethnic minority patients. It has, of course, been up to the scientific community to investigate the role of biology and biological differences and how cancers manifest and progress in individuals across different racial and ethnicity groups. Over the last decade, the scientific community has provided new and critical insights into differences in the biological makeup of cancers that were derived from underrepresented minority patients. And although we continue to advance these important discoveries, in order to make continued progress, one gap we face is in the limited diversity in our cohorts of patients in biomedical research. One area-specific need is a more diverse set of cancer model systems. We need these models to help us gain a broader and more comprehensive understanding of cancer and to validate findings in ways that does not force us to generalize results based on information gained from cohorts with little or no diversity. This comprehensive report provides key insights and updates on our knowledge of many of the key facets of cancer disparities. This includes progress in understanding the role of preventable risk factors such as tobacco use, obesity, alcohol consumption, and risk of exposure to cancer-causing viruses such as HPV. Our report also discusses disparities in cancer treatment and progress towards mitigating these disparities. The last 2 decades have seen amazing improvements in cancer treatment, including innovations in radiation therapies, development of targeted drug therapies, and more recently, advancements in cancer immunotherapies. However, we also know that the adoption and utilization of these blockbuster drugs and treatments has not always been effectively and equitably distributed to all patients, especially underrepresented minorities and those patients without private insurance. There is significant activity across all public and private stakeholders to address these issues. Interestingly, we're also monitoring clinical trials and patient demographics for COVID-19 vaccine and drug trials to ensure adequate racial and ethnic diversity, especially given the increased burden of this disease. Further, As we continue to work to mitigate cancer disparities, one approach that holds tremendous promise is the diversification of the cancer research workforce. As with cancer health disparities themselves, we face significant disparities in the demographics of the research workforce, particularly in STEM areas such as cancer research. This includes limited diversity across the continuum of science education from K through 12 all the way through academic faculty positions. However, progress has been made, but we still have a long way to go. For instance, our progress report references several programs, including the CURE program, which was developed through the NCI Center to Reduce Cancer Health Disparities. CURE, which stands for Continuing Umbrella of Research Experiences program, supports underrepresented minority trainees and scientists using a holistic approach to promote mentoring, professional support, and career-building skills. Finally, to support endeavors to understand and eliminate cancer health disparities, we must have robust public health policies and federal funding in place. Thus, we must continue to provide the critical and important evidence that's needed to craft policy that can have significant impact on reducing cancer disparities, such as policies to address obesity, poor diets, and physical inactivity. In closing, this inaugural and historic progress report, sponsored by AACR, will provide the world with a comprehensive baseline understanding of our progress towards understanding and eliminating cancer health disparities. This monumental report took the collective effort of a number of the world's foremost thought leaders in the area of cancer health disparities research and frames progress, but also initiates a call to action which rounds out the document, which we will address later. I am pleased to be joined by three distinguished colleagues who have made tremendous contributions to the development of this landmark report as fellow members of the steering committee. Each of them will speak in more detail about some of the key topics discussed in the report. First, I would like to introduce Dr. Shanita Hughes-Halbert, who serves as Associate Dean for Assessment, Evaluation, and Quality Improvement, as well as Professor and Endowed Chair in the Department of Psychiatry and Behavioral Sciences at the Medical University of South Carolina Hollings Cancer Center. Dr. Hughes-Halbert is a nationally recognized expert in cancer prevention and control among diverse populations. Her research focuses on identifying sociocultural, psychological, and environmental determinants of minority health and health disparities. Shanita.
My name is Shanita Hughes-Halbert, and I'm from the Medical University of South Carolina. I would like to start my remarks by thanking the American Association for Cancer Research for their leadership and support to generate the first progress report on cancer health disparities. For the past 2 decades, the AACR has been instrumental in shaping the field of cancer health disparities research by supporting the annual Science of Cancer Health Disparities Conference, developing new initiatives to enhance workforce development among underrepresented minority trainees and investigators, and supporting and promoting the discovery of novel cancer risk factors and therapies to eradicate disparities among racial and ethnic minorities and other underserved populations through groundbreaking research. This report on the progress that has been made to understand and address cancer health disparities highlights the multi-level determinants of racial and ethnic disparities in cancer risk and outcomes, and underscores the importance of the continued efforts and investments that are needed to conduct transdisciplinary translational research that can transform our healthcare systems, public health programs, and the communities in which we live, and ultimately eliminate disparities. As a behavioral scientist, the focus of my research is on developing, evaluating, and disseminating evidence-based strategies that address cancer health disparities. And as described in the AACR Progress Report, social determinants of health include the conditions in which individuals are born, live, work, and age. Social determinants of health include housing conditions, access to healthy food, literacy, employment, financial resources, and access to health care. It is important to understand and study social determinants of health in the context of cancer health disparities because these factors influence one's ability to obtain quality health care, increases their exposure to cancer risk factors, and reduces their ability to engage in cancer control behaviors. The AACR progress report highlights known disparities in exposure to cancer risk factors through physical inactivity, unhealthy eating, obesity, and smoking. Research is now being conducted to understand how adverse social conditions such as structural racism and discrimination promote physiological and behavioral stress responses that contribute to excess rates of morbidity and mortality among racial and ethnic minorities. This is a critical time for the field of cancer health disparities, where it is imperative that all stakeholders, which includes policymakers, regulators, payers, academic medical centers, healthcare providers, advocacy groups, public health organizations, and patients and caregivers, to work together to ensure continued progress is made towards cancer health equity, especially during this unprecedented time of a global pandemic that has changed the way in which cancer is diagnosed, treated, and patients recover from this disease. As part of these efforts, priority should be placed on increasing funding to the NIH and CDC to support translational behavioral science research to improve the precision of cancer control interventions in racial and ethnic minorities. Greater funding is also needed to support research and initiatives that enable healthcare systems, public health organizations, and scientists to collect the right data on social determinants of health so that their contributions to cancer health disparities can be studied rigorously. Thank you.
Thank you very much, Dr. Hughes-Halbert, for those outstanding remarks. I would now like to introduce Dr. Marcia Cruz Correa, who is the director of the Gastrointestinal Oncology Division at the Dr. Isaac Gonzalez Martinez Oncologic Hospital and is professor at the University of Puerto Rico Comprehensive Cancer Center. She also serves on the AACR Board of Directors and is the former chair of the AACR Women in Cancer Research Council. Marcia.
Good afternoon, and thank you for joining us. I am delighted to participate in this virtual congressional briefing to discuss the AACR Cancer Disparities Progress Report 2020, which features the latest research on underlying causes of cancer disparities in racial and ethnic minorities and other underserved populations. The report also includes urgent actions that must be taken to address this public health crisis. Every American is entitled to equitable access to life, liberty, and the pursuit of happiness. Disparities in healthcare are among the most significant forms of inequality and injustice. I will focus my remarks into three main areas: cancer screening, cancer clinical trials, and workforce-related issues. Let's start by screening. The goal of screening is to find precancer and cancer at the earliest possible time because this increases the chance for successful treatment. Screening is also associated with early diagnosis, increase in survival, and reduction in mortality from the cancer being screened for. Unfortunately, many people for whom cancer screening is recommended do not get screened, including a disproportionate number of racial and ethnic minority groups and underserved populations. Cervical cancer is one of the most common cancers in Hispanic American women, yet they exhibit low rates of cancer screening compared to white women. Similarly, colorectal cancer disproportionately affects certain minorities, including African Americans, Pacific Islanders, and Puerto Rican Hispanics. In fact, African Americans and Puerto Rican Hispanics are twice more likely to be diagnosed with colorectal cancer before the age of 50 compared to whites. Unfortunately, screening for colorectal cancer continues to be lower for U.S. minorities compared to whites. Multiple barriers to screening have been identified, including lack of access to health care, poor knowledge of cancer risk, mistrust of the healthcare system, and specifically for Hispanics, having English as a second language have been shown to be an important driver of disparity in cancer screening. Policies to reduce cancer screening disparities are needed, such as policies to secure research funding to define the biological and environmental differences in disease etiology among minorities. Also, culturally tailored strategies to increase cancer screening awareness access and uptake, including the utilization of patient navigators and advocates, as will be discussed by Dr. Wing. Let's switch gears and talk about clinical trials. Development and approval of anti-cancer drugs requires testing for safety and efficacy through clinical trials, routinely using 3 successive phases. Representation of diverse populations in cancer clinical trials is key to understand the biological differences in the drug's action among different people who are taking the drugs. However, low participation in clinical trials and lack of diversity among those who participate continues to be a challenge in clinical trials. It is well documented that racial and ethnic minorities are significantly underrepresented in clinical trials relative to their respective cancer burden in the United States. For instance, while 13% of the US population is African American, African American men are twice as likely to die from prostate cancer compared to whites. However, less than 10% of participants in the recent clinical trials that led to the FDA approvals of 2 new treatments for prostate cancer were African American men. Similarly, Hispanic children with cancer are 50% less likely to enroll in clinical trials compared with non-Hispanic white children. Urgent actions are needed to systematically address disparities in participation in cancer clinical trials. Among these, we will highlight, number 1, to establish policies for recruitment of racial and ethnic minorities in cancer clinical trials based on disease incidence rather than their proportion in the general population. Secondly, increasing trial availability by including community-based oncology practices. Thirdly, simplifying and expanding eligibility criteria. Fourthly, integrating patient navigators, community health workers, and patient advocates from the design, recruitment, and implementation of clinical trials. Lastly, expanding federal policies such as that included in the Affordable Care Act, requiring private insurance companies to cover routine medical costs of participating in clinical trials. Let's finalize by discussing workforce issues. Another important factor that contributes to cancer health disparities is the lack of diversity in the pool of trainees, researchers, and in the healthcare workforce in science and medicine. However, there is indeed underrepresentation of African Americans and Hispanics across the US healthcare workforce. When you look specifically at research scientists, Hispanics and African American scientists represent only 6 and 2% of biomedical scientists, respectively. Moreover, African American scientists are less likely to obtain federal research funding compared to other racial and ethnic groups. For physicians, we still see a small percentage of Hispanics and African Americans represented among physicians. In fact, in 2015, Hispanics and African Americans represented less than 6% of all physicians. Similarly, less than 3% of all practicing oncologists were Hispanics or African Americans for that same year. Physician scientists who care for patients and conduct research provide a unique perspective on how to translate scientific knowledge into healthcare and health policy. However, underrepresented minority MD-PhD students represent only 10% of all matriculates. The lack of diversity in the physician scientist workforce leads to lack of diverse role models and mentors. Limited representations of minorities are also seen among registered nurses, pharmacists, and other key healthcare professionals. Achieving health equity will require immediate actions to ensure diversity in the cancer workforce. Enhancing diversity in training and in the cancer workforce will expand the perspectives, will fuel innovation, and will guide science-based health policies that will advance cancer prevention, early detection, and treatments, and will ultimately promote health equity for every American. Thank you.
Thank you so much, Dr. Cruz Correa, for your amazing remarks and critical perspective. I am now pleased to introduce Dr. Robert Wynn, the director of the Virginia Commonwealth University Massey Cancer Center and professor of pulmonary disease and critical care medicine. A renowned physician scientist, Dr. Wynn is a pulmonologist whose scholarship has focused on lung cancer, health disparities, and community-based healthcare. Robert.
Good afternoon. My name is Dr. Robert Wynn. I am the Cancer Center Director of the VCU Massey Cancer Center here in Virginia. I want to thank you for the opportunity to present the Health Disparity Report to you, but I'd be remiss without thanking Dr. Foti and the AACR for their unwavering commitment to the eradication of cancer and to the reduction of health disparities. I'm reminded that we're coming up on the 50th anniversary of the National Cancer Act, which was an important act for all of us in cancer. This act occurred in 1971 and really was the beginning of what we consider to be the war on cancer. I'd like to report to you that that war is going pretty okay at the moment. Since 1971, we've made tremendous progress in fighting cancer. In fact, it's the first time in history that we can proudly sort of say that we have more people living with cancer than dying from it. In fact, in 2019, there are 17 million survivors of cancer. That's almost unheard of. We estimate in 2030, there will be about 20 or 22 million survivors, which, again, it's worth fighting for. Despite these successes, however, we know that our cancer survivors are actually faced with a number of challenges. Many of these challenges include things like financial toxicity. The amount it costs for these drugs are astounding, and the out-of-pocket costs are tremendous. This sometimes leads and puts our survivors at risk for things like bankruptcy. In addition to the financial toxicity, our survivors also, we know with our miracle drugs, sometimes actually do suffer some poor physical qualities of life associated with sometimes toxicity and sort of the side effects of some of these drugs. Some of them are cardiovascular, some are neural, and others. And we know that just having cancer is stressful. The truth of the matter is the emotional toll it takes on just the stress and the distress of this disease is certainly of significance. So we know while we're making some wins in the war, we are a long way from winning the war. The truth of the matter is, it's even more, as seen in the report, hard for some of our at-risk populations. In fact, many of our at-risk populations, including rural populations and minority underserved and others, actually not only are they feeling the same financial toxicities and physical disabilities associated with the physical impacts and the emotional toll, but they're feeling it in droves. In some cases, the disparity that actually happens as a result of different groups and their survivorship is actually haunting. Fortunately, with the implementation of things like the Patient Protection and Affordable Care Act, it has reduced some of the financial burden through the Medicare expansion and premium tax. We support this as Cancer Center directors and certainly as the AACR. It's also becoming increasingly clear that just having miracle drugs by themselves is not enough. It's also important to bring along the community as partners. In that case, it turns out that having patient advocates is not only a good thing, it's essential. And the goal here is to continue those programs to allow our patient advocates to not only sit at the table and have a voice, but to help us refine our scientific questions, refine the way we do clinical trials, and yes, even help us define the scientific questions that are being asked about their community. This work was actually inspired in this type of integration between the community and cancer a long time ago. And I'd actually credit folks like Dr. Harold P. Freeman, who was really a champion of making sure we promoted the use of things like community navigation in our communities to navigate women with breast cancers to the right places. He not only promoted the use of things like navigation, but he also was one of the true champions in trying to say that we should put as an equal amount of attention on the implementation science, that is the health delivery side of science, as we do on the discovery sciences. I think as a result of bridging that disconnect between our thirst for discovering the new drugs, but also how that gets implemented and executed and delivered to many other people, has really also been one of the key, I think, tools in our toolkit for how we've actually are starting to gain some traction in the war against cancer. We're also reminded every day that we are definitely in the throes of big science and big data. So bold efforts like the one at the NIH by the way of the All of Us program will help us greatly, even more, develop precise and precision approaches to how to actually make sure that an individual is not just a number, but an individual is being seen as themselves, and we can precisely attack the cancer for them and unique to them. I'm incredibly excited about where we are. I also know that there's one important element too that I failed to mention, and that is workforce diversity. We've had champions like Hannah Valentine and Dr. Sonia Springfield and folks, Dr. Bob Croyle and Dr. Henry Cialino and folks from the NIH and all in different areas of foundations, trying to make sure that we understand that to treat cancer, it needs multiple different voices and multiple different ideas. And the efforts around diversifying that workforce has really been, I think, a big impact. I'd have to tell you that I am a direct benefactor of those pipeline programs. And as the only African American to date, cancer center director of an NCI designated cancer center, I have to tell you that those programs have worked. Literally all the way from Head Start to being a cancer center director at VCU Massey Cancer Center. The core of all these efforts are rooted on evidence-based policies that are both guidelines for us and actually rallying cries for action for us. And a number of federal and state agencies will need to play an important role in coordinating efforts in addressing cancer health disparities reduction. We'll also need your continued funding of vital and innovative research. All those things will be needed to achieve the goal of eradicating cancer. I'd be remiss if I didn't actually recognize that some of this is actually going to be also embedded in strong support for public health policies. These policies will go a long way in reducing cancer health disparities by also giving attention and improving prevention and early detection efforts in a number of cancers. Proof positive that strong public health policies work: the reduction of lung cancer that we have, the improved cervical cancer rates where no woman should die from cervical cancer, and the improved rates of things like GI cancers. We're doing some, we certainly have more to do. The AACR looks forward to working with the Congressional Black Caucus, the Congressional Hispanic Caucus, the Congressional Asian Pacific American Caucus on their Health Equity and Accountability Act bill to eliminate health disparities experienced by at-risk communities. This bill should be a priority, and the AACR and cancer centers all across the country stand at the ready to partner on this important legislation. I want to thank you for your attention, and I want to let you know that we definitely have cancer warriors throughout the United States who know that this fight is not over, but we're certainly making progress, and we have more progress to make. Thank you.
Thank you very much, Dr. Nguyen, for those amazing remarks. One of the most inspiring and powerful aspects of this report is the inclusion of personal stories from cancer survivors who shared their experience with us. We are honored to share 2 of these stories with you today. First, we will show a video from our interview with Colonel Gary Steele from Carlisle, Pennsylvania. Colonel Steele is a survivor of both prostate cancer and multiple myeloma. Having joined and benefited from multiple clinical trials, Colonel Steele is a strong advocate for paying it forward so that others may have access to new and potentially life-saving treatments as well. Let's watch his video.
If I'm in a clinical trial and what I do helps someone down the road, then I've done something. I've paid it forward. My name's Gary Steele, and I'm a 23-year Army veteran, proudly served, and I've been married to my wife, Mona, for 48 years, and we have 3 children. I was initially diagnosed in 2011. So I went in for my annual checkup, and the doctor indicated to me that, wow, I see a bit of a spike in your PSA. They said, well, we recommend a biopsy. I remember the day I was out in the garage doing some work for my wife, and when the doctor said prostate cancer, for me, it was kind of like a big, dark gray cloud came over my head at that moment. The doctor said, well, there are a number of options. We think we might be able to go in using the Da Vinci method and get it all. And in July of 2011, I had the procedure. Then we started going through the process of the regular monthly checks for the PSA. And on the 26th month, the PSA showed a rise. Now the next step would be radiation. And then they tested me again, and my PSA had gone up again. Then it was, okay, so what do we do now? The options that we saw were to head down to Johns Hopkins to see what they thought. They said, well, we do have a clinical trial that we're looking to get some folks into. First of all, I wanted to see if I could take care of me. And then I started thinking about, if I'm in a clinical trial and what I do helps someone down the road, then I've done something. I've paid it forward. At the end of that year, my numbers went up. And it's really funny. It was like, yes, this is where you are right now, Gary, but great thing, there's another clinical trial that we're looking for folks to get involved with. Within about 6 months, my PSA went down to undetectable. In early 2017, one night in my little office upstairs, I went to get up from the chair, and I could not get up because the pain was so intense. So we called our doc, and he got me into the hospital over here and got a scan. There was a significant mass. It was multiple myeloma. It was funny. There was no dark cloud that came over me this time. I just figured, okay, this is just another hurdle. This is something that we can handle. We handled this other one, so let's handle this one. And also understand that there's no cure for multiple myeloma, but perhaps this can become something that we can maintain and become a maintenance issue. A very good friend of ours was diagnosed with multiple myeloma a number of years ago. And as part of her treatment, she was on a clinical trial for something that was called Revlimid. And then as I developed multiple myeloma myself and got into my treatment, the standard of care for me included Revlimid. I'm not doing well with this. So in my mind, it was because of her and folks like her who went into clinical trials that my treatment is now standard of care. And so I thank her, and I thank many, many other people for what they did to help me.
We would now like to share a video from our interview with Jessimy Lopez from Los Angeles, California. Ms. Lopez was diagnosed with aggressive triple-negative breast cancer at the age of 30. After her successful treatment, she became a survivor advocate and patient navigator and decided to pursue a doctorate in social work to help others address the social issues that lead to gaps in care. Let's watch her video.
People say that when you die, you see your whole movie of your life in front of you. I actually saw the movie of my life after they gave me the news. My name is Jessimy Lopez. I am 39 years old. I was at home and watching TV and I felt a lump. My husband said, well, you should get a check. I was diagnosed with triple-negative breast cancer when I had just turned 30 years old. People say that when you die, you see your whole movie of your life in front of you. I actually saw the movie of my life in those seconds after they gave me the news. Because of how dangerous that triple negative is, the doctor wanted to make sure that I had better chances of not having a recurrence. So she decided that I had to do chemo prevention. During the time of my chemotherapies, I had to undergo genetic counseling and genetic testing. And I tested positive for the BRCA1 mutation. The counselor told me, you have to ask, if there was any cancer in the family, what type. Every family member I asked on both sides of the family told me, no, there is no cancer. So one of my cousins called back after, and she said that she didn't want her mom to hear, but she had been a survivor of kidney cancer. It's a lot of lack of information and misinformation around because they don't want to confront the cultural taboos around cancer. I am currently in no evidence of disease. That means at the moment there is no test that can prove that I have cancer floating inside me. But I'm also mindful that that doesn't mean that it's not somewhere there. That's why I'm very excited about participating in cancer research, because we can at least find more answers. I remember the moment that I decided that I wanted to do something more than just being a cancer patient. I was feeling really down, and my genetic counselor came to visit. And she said, no, not only I need you, but many people in the community need you, because there is a high need for people who can be helping others who cannot speak at the moment. And I see that you have that potential. At USC, I joined the Norris Cancer Survivorship Advisory Council, and then I started joining other hospital boards and attending conferences.
Cancer is a roller coaster. It has ups and downs and curves, but mostly importantly, it's temporary.
I am so grateful of all these tables that were with a seat available for me, so I could represent the voice of other, not only Spanish-speaking patients, but underserved communities that may not have the opportunity to be educated, literate, or linguistically or culturally trained to understand what is out there for them. We want to continue funding research because we deserve to live longer. We are trying to make an impact for everybody in our community. And we want to make sure that our voices and the voices of all the people who have passed are still present. It's for my patients. It's for the generation that comes after, because we don't want to have to live through all these toxicities for the rest of our lives. If we can improve research and we can improve the treatments, I believe it's possible. I think we have really amazing, talented people around. And I think it's important that our elected officials that represent us, that we have all our hopes in their vote, that they think of us.
As stated previously, among the most important components of this progress report is its call to action. This call to action urges policymakers and stakeholders to work with us in our commitment to eliminating cancer health disparities. This call to action asks stakeholders to provide robust, sustained, and predictable funding increases for the federal agencies and programs that are tasked with eliminating cancer health disparities, to implement steps to ensure that clinical trials include a diverse population of participants, to support programs to make sure that the healthcare workforce reflects and appreciates the diverse communities it serves, to prioritize cancer control initiatives that include approaches to mitigating cancer disparities, and to work with members of the Congressional Tri-Caucus to pass the provisions included in the Health Equity and Accountability Act. On behalf of my colleagues, we feel a tremendous sense of pride in having the opportunity to craft this historical document. But more importantly, we maintain a sense of responsibility and purpose and remain resolute and steadfast in our efforts to reveal and expose the multitude of factors influencing these cancer health disparities that continue to plague, in many cases, the least of these. We must continue to reveal these factors and identify solutions as we continue our march towards true equity in cancer care and outcomes. But we can't do it alone. So I close with a quote from the late distinguished gentleman, Elijah E. Cummings. We've got to keep working together until there are no more disparities. Thank you. Thank you. Thank you all so much. If we can have our panelists unmute their mics and turn on their videos. I, again, can't imagine there being a more incredible moment in my entire career as today and being part of this historic event. I'd also like to thank all of our legislators for their care and their participation in this amazing program today. And I'd like to say to Congressman Thompson, I was raised in Leland, Mississippi, so I'm a member of your district. My family still lives there, and so we thank you for your efforts as we do all of our legislators. And so now we want to have a panel that will include a number of the individuals who participated in the program today, that include our two survivor advocates, Gary Steele and Jeshimi Lopez, and also Drs. Cruz Correa, Hughes Halbert, and Dr. Nguyen. And so we wanted to open up with a few questions, and taking the moderator's privilege, I would like to ask a question for Gary. So in that incredibly inspiring and powerful video interview that you gave, you mentioned that you had participated actually in several clinical trials. So what advice would you give to someone who's diagnosed with cancer and may be a little bit weary of enrolling in a clinical trial?
Dr. Carpenter, thank you very much for having me on today. And it's a kind of a two-part question as I see it. First, someone who is diagnosed with cancer. One of the first things I think an individual might consider is becoming educated, finding out as much about the disease that you're burdened with as you can, which we've tried to do a couple of times now. And the other part is being wary of a clinical trial. As I mentioned in the interview, once I became a little bit more knowledgeable, the next thing I did, I was very selfish, and I started thinking about myself. And I said, are there options? And once we got to the point that, hey, you've got what you got, but there may be a clinical trial that could help you. My wife and I, we jumped on that right away because that could help us. And then, I became a bit more altruistic, and I started thinking about, well, we have two sons. This is with prostate cancer. And there are other friends that I know that are involved in this. And so I thought that by my being involved with this, I'm, one, perhaps helping myself, and two, and equally as important, helping a lot of other people, paying it forward. That's my thought.
That's incredible, and we definitely get that, and your credo, right, of pay it forward. Take what you've learned and you've experienced and pass that along to someone else. So we really appreciate those comments. And I'd also like to ask a question for Jashimi. You've taken your experience with cancer and become an advocate, not only for yourself, but for others, including your family members. So can you tell us about some of the strategies that you might feel might be most effective in terms of reaching out to the community with information about cancer?
Thank you, Dr. Carpenter. Well, it has been a pleasure to be able to become a cancer research advocate, a survivor. I think that if we can use as a strategy, just develop genuine relationships with the community. I think that when you develop real relationships with people, you are able to connect in a better level, as well as integrating opportunities for the community to be trained and educated in cancer research, offer spaces where people can express their views and concerns. Many times just dispelling myths helps a lot. And using community-based and human-centered approaches, as well as partnering with multidisciplinary organizations that can step up the game.
That's outstanding. We thank you so much for those comments. I think they're spot on. We do have a few questions in the queue, and I think there's one that's really interesting. There are a lot of interesting questions and some amazing comments. But one of the questions, and I'd love to get Shanita's perspective on this. And so the question is, what is the response to last week's science publication? I think it's from Sarah Tishkoff's group about confronting the use of quote unquote race in genetic research as opposed to genetic ancestry, because that's what that paper is really getting at. And so what safeguards are in place to ensure that biological and genetic research isn't used to reinforce racism? And the question comes from Matthew Ryan, and he actually included the link to that paper from Sarah Tishkoff and her colleagues.
Yeah, thanks, John. That was such an important paper, and I think we all have to really always be reminded of the risk and the concerns that exist across the country in our communities about linking racial background with genetic information. I think, that this has been an area of intense investigation for a number of years. And what I would say is, while there are concerns, race is, I think, a really important in terms of our identity, how we identify as communities. And so I think more and more, the field is moving towards using ancestry as a way to understand our historical backgrounds and how our historical backgrounds influence our disease risk and outcomes today. So I think it's a really important area. I think we always have to be mindful of the way in which we describe different populations, different groups. And what's exciting, I think, is that there's an opportunity now for genetic scientists to interact and collaborate with behavioral scientists such as myself to really bring together the complex ways in which we all have sort of a shared experience as human beings, but how that differs socially based on our unique experiences in this country.
Yeah, and it's such an important question, and I think it also speaks to and you and Dr. Nguyen and others, and sort of the field's move towards really understanding actually how those two things intersect.
Right.
Right. That race brings with it specific social stressors, individual stressors, stresses from the built environment. These environments that have been built with very detrimental, that cause very detrimental environmental impacts that can lead to detrimental physiologies like chronic inflammation and things of that nature. Now you lay that on top of a baseline genetic ancestry, right, that is tuned for specific biologies, and now all of a sudden you've created this perfect storm of such. That provides a cancer, if it does manifest, with the opportunity to be even more, to take a more aggressive and a course for growth. And so I think as we move forward, we have to understand that we have to be very, very careful in using these social constructs and ensuring protection, but at the same time, understanding how these two things intersect.
Absolutely. And I would just underscore several things that you've described and discussed. I do think, there, as I said, there's concern, but I think we have the tools now to be more precise in how we understand our ancestral backgrounds. And that's exciting, but we also live where we live and how we live right now.
Yeah.
And so we can't eliminate that. So it just gives us a better context, I think, to understand the world in which we live today.
And so I think it's important to even mention that in our progress report, many of you have probably heard about the concept of precision medicine, by where you can take, environmental, genetic, biological information from each patient and use that information to make a more informed and precise course for disease management. However, the chapter that we drafted for this particular report is actually called The Imprecision of Precision Medicine. Because, well, actually, I would love for Shanita and Dr. Nguyen, as well as Dr. Cruz Correa, to address this whole issue of the imprecision of precision medicine as we take into the context cancer disparities specifically.
Just in the interest of not hogging the time, I mean, I certainly can talk, as you know, but I'll invite my colleagues to offer their remarks first, and then I'll chime in.
Yes, Dr. Nguyen.
I'll keep my comments brief. So, John, you know that I took great pride in being one of the first principal investigators for the All of Us program, because I honestly believe that there is some level to the DNA and unlocking the secrets of the DNA and how that relates to us. But the imprecision becomes because one size doesn't fit all. In fact, as we know, you were just hinting at this whole concept of where you live. In fact, the zip code and neighborhood of association probably determines your life expectancy and outcomes more so than many of the other factors. And so one of the things I really thought that the imprecision is that the imprecision comes because we only look at a gene. And then we say, well, we looked at this gene and now it's precise to you in this portfolio, not understanding that you could have a 59-year-old woman with the same, sort of breast cancer that responds differently to the same treatment, not simply because they have the same genetic profile, but because the epigenetic or the things that are happening on top of your genes as a result of where you live. The funny part about science is that as scientists, man, we love it because we love things that are reductionist. That's what we do. We want to reduce it so it's clean and it's easy. But big data is pushing us to understanding that we're going to have to be much more system oriented and it's not going to be as comfortable. But I do have the confidence that we have a lot of smart people around the United States. So we'll figure it out, if not today, someday. That's why research is important.
So that's fantastic. There was also a question, actually it was a comment about the utilization of telemedicine, particularly as we consider rural communities. We had a comment from one of our legislators early in the program about the use of telemedicine, for instance, in areas of rural Oklahoma. And so Dr. Cruz Correa, can you provide a little bit of additional context around the power of telemedicine?
Absolutely. First of all, thank you again. I'm so excited about this whole day that I have I'm just almost crying today. So thank you for the opportunity, and congratulations to Gary and Jessamy for being part of this, as well as the other survivors, Tristan and some of the others. So I'm a physician scientist, and one of the biggest barriers that we face when you're looking at different neighborhoods, right, and different backgrounds, is that not everyone has the ability, right, to come to participate not only for the clinical care, but also for clinical trials. So this pandemic, although it has been extremely difficult, and as we mentioned before, especially worse for the diverse population, has actually allowed us to change the way that we practice medicine. In fact, now many communities like the one that I practice on, we have standard telemedicine consults, where now not only we provide patient care, but we also talk about clinical trials. And I think I want to tie up the topic that was previously mentioned about the imprecision of precision medicine. If we don't incorporate people that have diverse backgrounds, and by that, of course, we know the biology, we will never be able to understand why a certain drug works better in group A versus group B. So I think that we can put both things together. We can talk about what is our biological predisposition, but then you have to put that into context of your experience. And for years we talk about epigenetics and the way that our genes are modified by the environment that we are not only we live, but also the moment that you're born, the time that you're conceived. So you could have a genetic profile that completely gets modified because of where you were conceived and that mother that took care of you. So this really becomes extremely complex, right? And I'm glad that Bob said that there's someone smart out there that will answer that either today or sometime later. But I think that you have to adapt and you have to make the best out of this pandemic. And I think we've learned that differences and the disproportion that we're seeing among our minorities, right, Latinos and African Americans and some other groups that are disproportionately affected by this disease, we can use telemedicine as a way not only to reach out, think about even screening, right, doing mammographies, right? It's difficult to do a mammography, but we can incorporate other things like breast exam, self-examination, and do it with the patient by doing telemedicine. So I am very supportive. I'm hoping that many of the clinical trials will now start incorporating e-consenting, which some of them, the NCI is actually working on multiple trials using e-consenting. So we can use this same method, so to speak with our patients, to tell them about the study, and to get them, enrolled and provide access.
Great. So that's thank you so much for that perspective, Dr. Cruz Correa, and tracking back a bit to the conversation about the integration of environment and biology. We do want to thank sort of our legislators, as well as the NIH and the National Cancer Institute, who've developed new programs out of the National Institute for Minority Health and Health Disparity, as well as the NCI Center to Reduce Cancer Disparities, to really promote and encourage interdisciplinary collaborative research studies between social scientists, environmental scientists, biological scientists, as well as clinicians, right, to really get at the heart of these differences. So thank you so much. There's another question. I think this is for Gary and Jeshimi, actually. So Chris Campbell says, both Gary's and Jeshimi's testimonies were very powerful. And so how do we as cancer care providers better establish trust with the community to tackle low engagement with minorities in clinical trials? And I'd love to hear both from Gary as well as Jeshimi and any of our other panelists, if you have comments to that. I think it's a tremendous question.
I'll take a stab at it. I think it's a good question, and it's a complex question. How do the providers link up better with the community?
Yes.
And
build trust.
To build trust. My initial thought is simply to be out there and be visible. Have community meetings, perhaps. B, have a little marketing operation, where you're in the newspaper, and be visible, be seen. Leaders have to, the military, leaders have to be seen by the troops. And leaders, the troops over time, perhaps, will begin to get some more trust with the folks. But it's all about being seen and being heard, and being personal to the extent that you can in community organizations, and talking. And over time, I think trust will come.
Jeshami, and actually, I would, this will probably be our last question, but I do want to at least give every one of our panelists an opportunity to speak into it because it is such an important question. So Jeshami, any comments that you would like to make about the relationship and building trust between the healthcare providers and the community to help us improve on increasing diversity in clinical trials?
I think the most important question would be, think like, how would we want to be treated, and how would we want our family members to be treated? Because if we are able to put ourselves in other people's shoes, the connection is going to happen. I think that many times there is a barrier between provider and patient as a relationship. And if we can see each other as the way you would treat with respect any family member or friend. I remember when I was going through my treatment, the first time the doctor explained that I was going to lose my hair, I asked the doctor, so how would you cut your hair? And she was like, why are you asking me that question? And I said, because you also have long hair like me, and how would you cut your hair if you're wearing my shoes? And it completely threw her off. So that's what we need to do.
This is Shanita. I would just want to echo what Ms. Lopez and Colonel Steele have said. Trust is really about the relationship you have with a patient and the provider. And I think there's an important opportunity to think about more effective ways of incorporating assessments of social determinants of health, because that's one of the ways, by asking patients about more about where they live, how they live, what their concerns are, what stresses they're facing in their lives outside of, a particular disease context such as cancer, the more I think providers and patients will be able to relate to one another as people. And I think that's really important for developing a more trusting relationship and reducing distrust that can exist with healthcare systems and that can exist with providers. So I do think there's emerging evidence about tools that can be used. There is a cross NIH initiative to develop short screening tools that can be used and implemented in clinical settings. But we need more funding and support for evaluating the clinical benefit and the impact of incorporating those screening assessment tools for social determinants into care, and understanding, how they can improve the quality of patient-provider interaction, both in terms of improving trust and reducing distrust, but also in terms of patient-reported outcomes and longer-term cancer outcomes such as morbidity and mortality.
Thank you so much for the perspective. Dr. Nguyen.
Yeah, I listen, the bottom line is you have to consistently show up and be there and be honest and transparent and be willing to share your weaknesses and what we don't know. Trust is, as people have said, the old saying, trust you get by the community drip by drip, but when you lose it in buckets. And in fact, one of the biggest things I'm learning is that we have to be consistent in our approaches and consistent in our showing up, and that over time, actually not, inviting, as we talk about inviting the community, sort of saying, well, we want to invite the community at the table. Well, we know that centerpieces are also at the table, and centerpieces are beautiful. And at the end of your meeting, the centerpieces are usually thrown in the corner. So I'm not looking to engage my community. I'm looking to involve and integrate my community. And I think that from that perspective, the reality is that if we trust ourselves enough, and we know that we have trust within the community, that over time, when you make yourself, a little bit transparent and have the humility of understanding that we're probably going to learn as much as we're going to teach, things can actually happen.
John.
That's amazing. Thank you so much for that perspective. We've had a few questions about getting access to the video or any slides in the report, and I just wanted to make the AACR staff aware of that. And so in closing, I would like to thank, of course, Dr. Foti and the AACR again for their incredible commitment and working with all of the important stakeholders as we work towards eliminating cancer health disparities. I would also like to thank all of the members of Congress who participated in this program, and special thanks to Gary and Jeshimi as our patient survivors and advocates who provided just incredible context around cancer health disparities. And then lastly, I would be remiss if I didn't personally thank the members of the steering committee. What an amazing labor of love crafting this document was. But I would really like to send a special thanks to Dr. John Carruthers from the University of Michigan, Dr. Graham Colditz from Washington University in St. Louis, Dr. Marcia Cruz Correa, Dr. Shanita Hughes Halbert, Dr. Rick Kittles from City of Hope Comprehensive Cancer Center, Dr. William Nelson from Johns Hopkins University, Dr. Lisa Newman from Weill Cornell Medical School, Dr. Brian Rivers from Morehouse School of Medicine, Mary Scroggins from Pinky Hugs and Sisters in Care, Dr. Sonia Springfield, Dr. Mariana Stern from University of Southern California, Norris Comprehensive Cancer Center, and of course, Dr. Nguyen. So thank you all for your attention, and thank you for sharing with us the importance of eliminating cancer health disparities, and we will continue to fight on. Thank you for your attention.